pregnancy continue, page 1735. Symptoms. Early complaints are consistent with those of the normal pregnancy. Example, amenorrhea, breast tenderness, nausea. Pregnancy test results are positive owing to the presence of human chorionic gonadotropin HCG in blood and urine. Signs and symptoms arise as the growing embryo distends the fallopian tube. Associated complaints include intermittent unilateral colicky, abdominal pain. Complaints as associated with tubal rupture include sharp unilateral pelvic or lower abdominal pain, orthostatic dizziness, and vertigo or syncope, and referred shoulder pain related to peritoneal irritation from abdominal bleeding, hemoperitoneum. Signs of hypovolemic shock may indicate extensive abdominal bleeding. Vaginal bleeding typically occurring after the onset of pain is the result of this residual sloughing. Locations. Abdominal. The incidence of pregnancy in the abdominal cavity with the conceptress attached to an abdominal organ is between 1 to 3,000 and 1 to 4,000 births. Ovarian conception and implantation within the ovary itself occurs in approximately 1 in 7,000 to 1 in 50,000 pregnancies. Tubal. 90 to 95% of ectopic pregnancies occur in the fallopian tube. Of these, 78% become implanted in the uterine ampulla, 12% in the isthmus, and 2% to 3% in the interstices. Diagnosis. Transabdominal pelvic ultrasonography is used to identify the location of the pregnancy if it has also largely replaced chodocentesis for confirmation of hemoperitoneum. Treatment. An operative approach is most common. Laparoscopy and linear laser salpingostomy can be used to exercise early ectopic implantations. Healing is by the secondary intention. Segmental resection allows salvage and later reconstruction of the affected tube. Salpingectomy is reserved for cases in which tubal damage is so extensive that reanastomosis is not possible. Methotrexate has been used successfully to induce insolution of unruptured tubal masses less than 3.5 centimeter. Post-treatment monitoring includes serial quantitative B-HCG levels to be certain that the pregnancy has ended. Patient care. Preoperative. The patient is assessed for pain and shock. Ectopic pregnancy should be considered as a possible diagnosis for all female patients of childbearing age until proven otherwise in the hospital setting. Vital signs are monitored and oxygen administration by non-rebreather mask is started. An IV fluid infusion via a large bore cannula is started and bloods are drawn to type and cross, including RH compatibility for potential transfusion. Medications including RhoGAM if the patient is RH negative may be prescribed and administered, and the patient's response evaluated. The patient's and family's wishes regarding religious rites for the products of conception are determined. Both patient and family are encouraged to express these feelings of fear, loss, and grief. Information regarding the condition and the need for surgical intervention is clarified. Post-operative vital signs are monitored until stable. Incisional dressing are inspected. Vaginal bleeding is assessed, and the patient's physical and emotional reactions to the surgery are evaluated. Prescribed medications are administered. The reefing process is anticipated, and both the patient and family are referred to further counseling as needed. See nursing diagnosis appendix. Extrauterine pregnancy, ectopic pregnancy, false pregnancy, pseudocyesis, heteropic pregnancy, combined intrauterine and extrauterine pregnancies. High-risk pregnancy, a pregnancy in which maternal factors such as diabetes mellitus, hypertension, kidney disease, vital infections, vaginal bleeding, multiple pregnancies, substance abuse, age under 17 or over 35, or toxic exposures are present. Pregnancy in association with these conditions is more likely to compromise the health of the mother or developing fetus than are normal pregnancies. Hydatid pregnancy, pregnancy giving rise to a hydatidiform mole. See gestational trophoblastic hydatic mole. Interstitial pregnancy, rare conditions in which the zygote implants in the portion of the fallopian tube that traverses the wall of the uterus. In mural pregnancy. Intraligamentary pregnancy, pregnancy that occurs within the broad ligament. Mass of pregnancy, cloasma gravidarum. Membranous pregnancy, pregnancy in which the amniotic sac ruptures and the embryo comes to lie in direct contact with the uterine wall. Mesenteric pregnancy, tuboligamentary pregnancy, molar pregnancy, pregnancy in which instead of the ovum developing into an embryo, it develops into a mole. See gestational trophoblastic D multi-fetal pregnancy reduction in multiple pregnancies, example triplets, quadruplets. The procedure for reducing the number of fetuses to minimize the risk of maternal and fatal complications later in the pregnancy. Multiple pregnancy, the presence of 2 or more embryos in the uterus. If drugs are not used to promote fertility, the incidence of natural twin pregnancies is 1 to 94. However, 20% of women who have undergone treatment with fertility drugs develop multiple pregnancies. As many as 40% of the naturally occurring twin gestation are undiagnosed. In about 1/2 of twin pregnancies, the diagnosed by ultrasound early in the first trimester, one twin will silently abort, and this may or may not be accompanied by bleeding. This has been termed to vanishing twin. The incidence of the birth defects in each embryo of a twin pregnancy is twice that is singular pregnancy. See parabiosis.